Let's jump straight into something absolutely fundamental to what we do in radiation oncology, balancing tumor control with protecting healthy tissue.
Exactly. Today, we're taking a look at the core radiobiology that really underpins every treatment plan you'll create. We're talking therapeutic ratio, the factors that influence it, and, some ways we try to measure and improve it. This is really crucial stuff.
Especially for boards, right?
Definitely.
So we're going to unpack that essential concept, the therapeutic ratio, look at what really drives our ability to control a tumor with radiation, explore some of those predictive tests people talk about, and then tie it all back into clinical decisions and those high-yield points you just have to remember.
Think of it as like a foundational review connecting the biology to the clinic.
Yeah.
And to those exam questions too.
Okay, so the absolute cornerstone here is the therapeutic ratio. You also hear it called the therapeutic index sometimes. What exactly is this ratio really getting at?
Well, at its heart, it's the difference, right? The difference between the dose we need to control the tumor and the dose that causes unacceptable damage to the normal tissues nearby.
It's the window we have to work in.
Precisely. It's that therapeutic window.
Yeah.
And our entire goal always is to make that window as wide as possible.
And we visualize this beautifully with those classic dose-response curves, don't we? You've got the tumor control probability curve, the TCP curve.
And the normal tissue complication probability, or NTCP, curve.
Yeah, both look kind of similar in shape.
They do. Both follow that characteristic sort of sigmoid shake when you plot them against dose. The TCP curve shows, how the likelihood of controlling the tumor goes up as you increase the dose.
Right. It plateaus eventually towards 100%, hopefully.
Hopefully. And the NTCP curve shows how the probability of a complication increases with dose, also plateauing.
So the therapeutic ratio is basically how far apart those two S-shaped curves are, horizontally speaking.
You got it. That's separation. A favorable therapeutic ratio means the TCP curve is nicely shifted to the left compared to the NTCP curve.
Meaning you can get good tumor control at a dose that doesn't cause too much trouble.
Exactly. You can achieve a high probability of tumor control at a dose where the probability of severe normal tissue complications is still pretty low. Think about treating Hodgkin's lymphoma. That's often held up as an example, right? High TCP, low NTCP at the same dose. That's the ideal.
Absolutely. High chance of cure, acceptable toxicity. But then you have the opposite situation too, an unfavorable therapeutic ratio.
Yeah, and that's where those curves are really close together. Or maybe they even overlap significantly. It's a much, much tougher scenario.
Like some specific cancers.
Like treating pancreatic cancer or maybe high-grade gliomas. The dose you need for even a decent chance of tumor control comes with a pretty significant risk of major complications. The window is just really narrow.
And fundamentally, I guess, a lot of radiobiology research is constantly trying to improve this ratio.
That's a huge driver. Exactly. We're either trying to shift that TCP curve left, make the tumor more sensitive so we need less dose, or shift the NTCP curve to the right, make the normal tissue more resistant so it can tolerate a higher dose without, unacceptable toxicity. Widen that window either way.
Okay, so let's dig into that TCP curve a bit more. What are the big biological drivers? What dictates its position, its slope? What makes one tumor easier to control than another biologically?
Okay, there are a few major players you absolutely need to know for your exams and practice. First up, and maybe the most intuitive one, is tumor size.
Okay.
Which directly relates to the number of clonogenic cells, to the cells that can actually regrow the tumor.
Right, it makes sense. The more cancer cells you start with that can potentially regrow the tumor, the more of them you have to actually kill off.
Exactly. If you have, say, a 1-gram tumor, that's roughly, 10 to the power of 9 cells, something like that?
1 billion cells.
Wow. Yeah. So to achieve control, you essentially need to zap enough of them so the average number of surviving clonogenic cells drops below 1. That takes many logs of cell kill.
Maybe 9 or 10 logs for that size.
At least. And the point is, the larger the tumor, the more logs of kill you need, which means you need a higher radiation dose overall. So larger tumors shift that TCP curve.
To the right. Needs more dose for the same control probability.
Precisely.
Okay, size makes sense. What else is key?
Then there's the intrinsic radiosensitivity of the tumor cells themselves. Think of it as their inherent weakness or vulnerability to radiation damage, independent of size or oxygen or anything else.
And how do we measure that? I remember seeing things like D0 or alpha-beta values.
Right. Those come from cell survival curves. D0 is from the older target theory, but the alpha and beta values from the linear quadratic model are what we mainly use now.
So high intrinsic radiosensitivity means?
It means that the cells are easily killed. They'd have a low D0 or, more importantly, a high alpha value in the LQ model, a bigger punch from the initial damage.
And critically, these more sensitive tumors have their TCP curve shifted where?
To the left, you need less dose to get the same level of control. And conversely, intrinsically radioresistant tumors, low alpha, for example, require higher doses, shifting the TCP curve to the right.
Now, a really practical measure you hear about a lot is the SF2 value, the surviving fraction at 2 gray. Why that specific dose?
Good question. It's because 2 gray is such a common dose per fraction in clinical radiotherapy, isn't it?
Yeah, very standard fraction size for many treatments.
So measuring the fraction of cells that survive after that specific clinically relevant dose gives us a quick snapshot. It's a practical surrogate for how resistant or sensitive the cells are likely to be in a typical treatment schedule.
And a lower SF2 means?
Fewer cells survive that standard 2 gray dose. So lower SF2 means higher sensitivity.
Got it. Okay, so we have size and intrinsic sensitivity. What's next on the hit list?
Tumor oxygenation status. This one is huge, absolutely massive. Hypoxia or low oxygen levels within the tumor.
Is bad news for radiation effectiveness.
Very bad news. It's a major cause of radioresistance, especially for the kind of radiation we mostly use, low LET radiation, like X-rays or photons.
And why is that again? The oxygen fixation hypothesis.
Exactly. Oxygen needs to be present during or immediately after irradiation to fix the free radical damage to DNA, making it permanent and harder for the cell to repair. No oxygen, less fixation, more repair, more survival.
And how much difference does oxygen really make? Is it a small effect?
Oh no, it's quantified by the oxygen enhancement ratio, the OER. And for low LET radiation, the OER can be as high as 2.5, even 3.0.
Wow, so hypoxic cells can be literally 2.5 to 3 times more resistant.
Yes, than the well-oxygenated cells sitting right next to them in the same tumor.
Yeah.
So a tumor with significant hypoxic regions will have its TCP curve shifted way over to the right. Needs much higher doses.
That's a huge factor. Okay, what's the last major one influencing TCP?
I'd say cellular heterogeneity and repopulation kinetics. Two related things. First, tumors aren't just uniform clones. They're messy, heterogeneous populations of cells. Different sensitivities, different growth rates. And second, critically, during a course of fractionated radiation that lasts weeks, the surviving tumor cells don't just sit there. They can divide and proliferate. They repopulate.
Which is essentially fighting back against what we're trying to do with each fraction. We kill some, they grow back between treatments.
Exactly. Rapid repopulation during treatment means you're effectively losing ground. The net cell kill is less than you'd expect just from the dose delivered. This effectively shifts the TCP curve to the right during the course of treatment.
And that's why overall treatment time matters so much for some tumors.
Precisely. Especially for tumors known for fast repopulation, like many squamous cell carcinomas in the head and neck. Reducing the overall treatment time becomes crucial.
Okay, so if you're trying to quickly remember those key factors that push that TCP curve around, what's a good way to think about it?
Well, you could think of them as SOR.
SOR.
Yeah. Size, cell number, oxygenation, hypoxia, radiosensitivity, the intrinsic kind, and repopulation and heterogeneity. Those are really the big four biological drivers of TCP.
SRR. Okay, I can remember that. Size, oxygenation or radiosensitivity, repopulation.
Exactly. And given how important these are, wouldn't it be incredibly useful if we could actually measure some of these things in a patient's tumor before we start treatment?
Absolutely. Which brings us perfectly to the world of predictive assays, the whole idea of personalizing therapy based on the specific biology of that patient's tumor and maybe even their normal tissues.
Right. Now, we should say up front, while this is a huge area of research and really important conceptually, using these routinely to tailor dose for every patient isn't quite standard practice yet. But understanding them is critical.
Especially for exams and for understanding where the field is heading.
Definitely. So for predicting intrinsic radiosensitivity, what's considered the gold standard, at least in the lab?
That would be the clonogenic survival assay, right?
Correct. Where you actually take cells from the tumor, irradiate them at different doses in a dish, and literally count how many individual cells survive and manage to grow into a colony over a week or two.
Gives you the full survival curve, the alpha, the beta.
Everything. But like you said, a week or two, that's often too slow for clinical decisions.
Right. You need to start treatment sooner. So people look for faster surrogates.
Exactly. And that SF2 value we just discussed, that comes directly from this assay. It's just looking specifically at the survival point after 2 grapes. It's a practical snapshot.
Okay. And are there even faster ways?
Yes, there are colorimetric assays, things like the MTT or MTS assays. These are much quicker, maybe taking only a few days.
How do they work? They don't measure colonies, right?
No, they don't measure clonogenic survival directly. They use special dyes that change color based on the metabolic activity of the cells. So they measure metabolism as a proxy for cell viability or number. More color change means more viable cells.
So faster, higher throughput, but maybe less directly measuring the ability to regrow.
That's the trade-off. But they can be useful.
Okay, and you sometimes hear about other methods, like the Courtney assay, or looking at chromosomes.
Yeah, the Courtney assay is a variation where cells are grown in soft agar, sort of like mini tumors. And assessing chromosome damage, like counting dicentric chromosomes after a test dose, is another way to gauge sensitivity. But that's technically quite complex and not really used routinely for prediction.
So for intrinsic sensitivity, clonogenic is gold standard, SF2 is a key practical value from it, and MTT, MTS are faster surrogates.
Got it. Good summary. Now, shifting gears, how do we try and predict that other huge factor? Tumor oxygen status or hypoxia?
This seems really important if it makes cells 3 times more resistant.
It is. And the most clinically advanced methods here involve using labeled nitroimidazoles.
Okay, what are those?
These are special compounds like mesonidazole or pimonidazole that have a neat property. They get metabolically reduced and trapped specifically inside hypoxic cells. They don't get trapped well in oxygenated cells.
Ah, so they accumulate where there's no oxygen.
Exactly. And if you attach a radioactive ligand to them,
You can image where they've accumulated.
precisely. The key technique here, the one that's actually used clinically in some centers, especially in trials, is fluorine-18 MISO positron emission tomography, F18 mesopet.
So the PET scan basically lights up the hypoxic parts of the tumor.
That's the idea. It gives you a non-invasive map of hypoxia.
Are there other ways using similar compounds?
Yeah, other labeled nitroimidazoles can be used with SPECT imaging, though PT is generally higher resolution. And you can also use non-radioactive ones, like pimonidazole. You give it to the patient, wait a bit, take a biopsy, and then use antibodies in the lab immunohistochemistry to detect where the pimonidazole got trapped in the tissue sample.
Okay, so imaging or biopsy detection. What about actually measuring the oxygen level directly?
You can do that too using oxygen probes. The classic example is the Eppendorf probe.
How does that work?
It's basically a very fine needle electrode, a polarographic electrode that you carefully insert directly into the tumor. And it measures the partial pressure of oxygen, the PO2, right there at the needle tip.
Wow, that sounds pretty invasive.
It is invasive, yes. And a big limitation is that it only samples a tiny spot. And we know tumor oxygenation can vary wildly from place to place within the same tumor.
Like microregional variations?
Exactly. So while it gives you a quantitative real-time measurement, it's invasive, only samples small areas, and it's just not practical for routine clinical use in most situations.
Makes sense. Are there any other markers, things the tumor itself makes when it's hypoxic?
Yes, there are endogenous markers.
Yeah.
These are proteins that the tumor cells naturally start producing more of when they're under hypoxic stress. The big ones to know are HIF1 alpha, hypoxia-inducible factor 1 alpha, and also C9, carbonic anhydrase 9.
And you detect those how? Biopsy again.
Yeah, usually detected by immunohistochemistry on biopsy specimens. You stain the tissue with antibodies against HIF1 alpha or CAIX. The challenge sometimes is that their levels might be influenced by other factors besides just hypoxia, so specificity can sometimes be an issue.
It's really interesting how many different angles people have taken to try and measure these critical biological features.
Absolutely, the need is clearly there.
Now, thinking about the broader clinical picture, how does all this connect back to things like pathology reports or tumor staging? We mentioned tumor size right at the start.
Right, and while we're not diving deep into specific AJCC staging criteria today, that very first factor we talked about, tumor size, which is a direct reflection of the number of clonogenic cells, is a fundamental part of both the pathological assessment of a tumor and its clinical stage.
So a larger tumor, whether measured by the pathologist on the specimen or seen on imaging for staging, simply means a higher initial cell burden.
Which, as we said, directly implies needing more cell kill, likely a higher radiation dose for control, and thus influences where that TCP curve sits. Size is baked into staging for a reason.
And can the pathology report give other clues sometimes, like tumor grade?
It can offer hints, yes. Understanding the inherent pathology, like a high tumor grade or a specific aggressive histological subtype, might suggest to the clinician that, for instance, rapid repopulation could be a bigger concern. Or sometimes certain subtypes are known to be generally more or less radiosensitive.
But these are more like general correlations, not precise predictions like the assays aim for.
Exactly. Pathology gives important context, but these predictive assays are trying to get a more direct, quantitative measure of that specific tumor sensitivity or oxygenation.
Okay. So what about the evidence? Do these assays actually predict how patients do? Have studies shown that link?
Yes, absolutely. There's a body of evidence, particularly from studies maybe a decade or two ago when these concepts were being heavily investigated clinically, for SF2 and intrinsic radiosensitivity. Studies by groups like Catherine West and colleagues, particularly looking at cervical cancer, showed a pretty clear correlation. Tumors that had a lower SF2 value, meaning they were intrinsically more sensitive, were associated with significantly better local control rates after radiation therapy.
So it did predict tumor response. What about the flip side? Normal tissue.
Good point. There's evidence there too. Some studies measured SF2 values from normal tissue cells, like fibroblasts taken from skin biopsies of patients before treatment. And they found correlations between those fibroblast SF2 values and the severity of late radiation side effects, particularly fibrosis. Patients whose normal fibroblasts were more sensitive, lower SF2, tended to experience more severe late complications.
Wow. So SF2 seemed to predict sensitivity for both tumor and normal tissue. That's really key for the therapeutic ratio, isn't it?
Absolutely critical. It highlights that intrinsic sensitivity is a double-edged sword. Now, what about the evidence for the hypoxia assays? Did they pan out? Definitely, especially those studies using the invasive Eppendorf probes. Seminal work by Michael Huckel, again in cervical cancer, showed a very strong correlation.
What did they find?
They found that tumors with low pre-treatment PO, two values meaning the probes measured significant hypoxia, had markedly poorer local control and even poorer overall survival compared to patients whose tumors were measured as being well oxygenated.
So the direct measurement of hypoxia strongly predicted outcome.
It did. It provided compelling evidence that hypoxia is a clinically relevant resistance factor.
And those faster assays like MTT.
The evidence there is maybe more about correlation with the gold standard. Studies, including work from researchers like Dr. James Mitchell at the NCI, showed that results from assays like MTT and MPS generally correlated well with the results from traditional clonogenic survival assays across different cell lines.
So they showed potential as faster surrogates, maybe for screening?
Exactly. Validating them as independent predictors of clinical outcome in large trials is a further step. But they showed promise as high-throughput tools, even if they aren't routinely used for individual patient prediction today.
Okay, this is great context. Let's try and distill some of this down into really high-yield clinical pearls. The absolute must-know takeaways for residents studying this.
Sounds good. Pearl number one, the therapeutic ratio. It's everything. It's that critical balance between tumor control probability, TCP, and normal tissue complication probability, NPCP. Your fundamental goal in planning is always, always to maximize this window.
Got it. Maximize the window. Pearl number two.
Remember those key biological factors that shift the TCP curve. Think SORR.
Size, oxygenation, radiosensitivity, repopulation.
Exactly. Size, cell number, oxygenation status, hypoxia is bad. Intrinsic radiosensitivity, often probed by SF2, and cellular heterogeneity and repopulation. Know those four.
Okay. Pearl number three, predictive assays for sensitivity.
Know that the clonogenic assay is the in vitro gold standard. But remember the practical surrogates. SF2, survival is 2G, and faster colorimetric assays like MTT and MTS.
And pearl number four, predictive assays for hypoxia.
The clinically relevant ones to really know are the labeled nitroimidazoles, especially F18-MISO-PET imaging for non-invasive mapping. And remember the direct but invasive oxygen probes like Eppendorf that measure PO2.
Excellent. SORR, SF2, MISO-PET, therapeutic ratio. Got it.
Now, how do these concepts, even if we aren't running MISO-PETs on everyone, how do they inform our day-to-day clinical decision-making?
They provide the essential biological framework, right? They help us understand why tumors might behave differently, why treatments sometimes fail, and they guide our thinking about potential adjustments or strategies, even based on clinical information alone.
Give me an example, like a mini case.
Okay, sure. Let's say you have a patient presenting with breast cancer, and during the workup, genetic testing reveals they carry an ATM mutation. ATM. That immediately rings bells for increased radiosensitivity, particularly in normal tissues. Ataxia telangiectasia.
Exactly. Now, you're probably not going to order an SF2 assay on their skin fibroblast. That's not routine. But knowing about that ATM mutation, understanding the underlying biology of defective DNA repair.
You'd be extremely cautious about normal tissue tolerance.
Absolutely. You would dramatically alter your treatment planning approach.
Yeah.
You'd be much more stringent with dose constraints to organs like the heart and lung, maybe use more sophisticated techniques to spare normal tissue, recognizing that this patient's normal tissues might be far more sensitive than the average person's. Their NTCP curve is likely shifted left.
Makes perfect sense. Okay, another example, maybe related to hypoxia.
Sure. Let's say you have a patient with a very large, bulky tumor, maybe in the head and neck region, and maybe they're also quite anemic. Clinically, you'd have a strong suspicion this tumor might be significantly hypoxic, right?
Yeah. Large size, poor blood supply implied by bulk, and anemia reducing oxygen carrying capacity all point towards hypoxia.
So even without a meso PET scan, that biological understanding might make you think differently. You might more actively look for clinical trials involving hypoxia-modifying agents for that patient. Or in some research settings, it might prompt consideration of dose escalation strategies targeting presumed resistant hypoxic subvolumes, though that's technically very challenging.
So the biological concepts guide your thinking and potentially your strategy.
Exactly. And we actually do use drugs sometimes specifically to widen the therapeutic ratio by protecting normal tissues. Think about amifostine.
Right, amifostine, also known as WR2721. How does that fit in?
It's a classic example of a radioprotector. It's preferentially taken up and activated in normal tissues compared to tumors, and acts as a potent scavenger of free radicals generated by radiation.
So it protects the good guys.
Essentially, yes. By reducing damage in normal tissues, it's been shown to reduce specific toxicities, like xerostomia, dry mouth, and head and neck cancer patients receiving radiation. It effectively shifts the NTCP curve to the right, improving the therapeutic ratio in practice.
That's a great clinical link. Now, beyond drugs or assays, one of the most fundamental ways we try to improve the therapeutic ratio in everyday practice isn't fancy, it's just how we deliver the radiation, right? Using treatment techniques like fractionation.
Absolutely fundamental. Dividing the total radiation dose into multiple smaller fractions, the core principle of fractionation is arguably the single most important strategy we use to exploit biological differences and improve the therapeutic ratio.
How does splitting the dose help widen that window?
It leverages the famous 4Rs of radiobiology, but especially repair and repopulation. Normal tissues are generally better at repairing sublethal radiation damage between the daily fractions compared to many tumor cells.
Okay, so normal tissue recovers better day to day.
And also, repopulation tends to be slower or more controlled in normal tissues compared to the rapid proliferation some tumors can exhibit during the treatment course. So, over weeks of treatment, fractionation preferentially spares normal tissues relative to the tumor, effectively widening that therapeutic window compared to giving the same total dose all at once.
Makes sense. And when we know a tumor is prone to that rapid repopulation we mentioned, like some head and neck cancers, what modification to fractionation might we consider?
That's where accelerated fractionation comes in. The idea is to deliver the total radiation dose over a significantly shorter overall time period.
Like treating twice a day or 6 days a week?
Could be, yes. By shortening the overall treatment time, you give those rapidly repopulating tumor cells less time to grow back between the start and end of therapy. You're trying to counteract that rightward shift of the TCP curve that happens due to repopulation during a long standard treatment.
Got it. One more technique concept. What about different types of radiation, like high LET?
Right. High LET, linear energy transfer radiation. Think neutrons or heavy ions like carbon ions. The way these particles deposit energy is much denser than photons or electrons, which are low LET.
And how does that affect the biology, particularly regarding oxygen?
Critically, the cell-killing effect of high LET radiation is much less dependent on the presence of oxygen. The damage is more direct, more complex, harder to repair regardless of oxygen status.
So the OER is lower?
Much lower. The oxygen enhancement ratio for high LET radiation might be closer to 1 or 1.5 compared to 2.53 for photons. This means high LET radiation could potentially offer a biological advantage for treating those really hypoxic, radioresistant tumors where the low OER negates much of the hypoxia-induced resistance. Access is limited, of course.
Fascinating. Okay, I think we've covered a lot of ground. Ready for a quick board blitz to see if it's sticking?
Let's do it. Fire away.
Question 1. The surviving fraction at 2 gray, or SF2, is often used as a predictive assay for intrinsic cellular radiosensitivity. A lower SF2 value generally indicates A, higher radioresistance and poorer tumor control. B, higher radioresistance and less severe late normal tissue effects. C, higher radiosensitivity and better tumor control. D, higher radiosensitivity and less severe late normal tissue effects.
Okay, lower SF2 means fewer cells survive 2G. That means they're more sensitive. For tumors, more sensitivity generally means better tumor control. So that sounds like C.
C is correct. Higher radiosensitivity and better tumor control. Perfect.
All right, next.
Question 2. Which of the following imaging techniques is most commonly used clinically to non-invasively identify hypoxic regions within tumors? A, dynamic contrast-enhanced CTV Eppendorf oxygen probe measurements. C, fluorine-18 FDG-PET, defluorine-18 MISO-PET.
Okay, non-invasive imaging of hypoxia. DCECT is perfusion. Eppendorf is invasive. FDG-PET is glucose metabolism. F18 MISO-PET uses that nitroimidazole tracer trapped in hypoxic cells. Has to be D.
D is the answer. Fluorine-18 MISO-PET. Nicely done.
Shit, number 3.
Question 3. Emifostine, also known as WR2721, aims to improve the therapeutic ratio primarily by A, selectively sensitizing hypoxic tumor cells to radiation. B, inhibiting DNA repair in tumor cells. C, preferentially protecting normal tissues from radiation damage. D, enhancing tumor reoxygenation between radiation fractions.
Amifostine, that was the radioprotector. It preferentially shields normal tissues by scavenging free radicals, so its main job is C, protecting normal tissues.
C is absolutely right, preferentially protecting normal tissues. Okay, last one brings a few concepts together.
Lay it on me.
Question 4. A tumor that is large, poorly vascularized, and contains cells with a high SF2 value would likely have a tumor control probability, or TCP curve, that is. A, shifted to the left and steep. B, shifted to the right and steep. C, shifted to the left and shallow. D, shifted to the right and shallow.
Okay, let's break down. Large size means more cells, needs more dose shift right. Poorly vascularized suggests hypoxia, needs more dose shift right. High SF2 value means intrinsically resistant, needs more dose shift right, so definitely shifted right. Now, steep or shallow. Resistance often makes the dose response curve shallower. You need bigger increases in dose to get gains in control. So I'm going with D. Shifted to the right and shallow.
And D is the correct answer. Large size, hypoxia, intrinsic resistance all push the curve right, and resistance often leads to a shallower slope. Fantastic.
Good questions. They really test the integration of the concepts.
They do. And as we've touched on, while these assays and concepts are powerful, there are real controversies and advances around their routine use.
Exactly. We have these potentially powerful predictive tools, but making them standard practice for tailoring individual patient treatments, well, that's still largely an ongoing effort. It's not widespread yet.
Why not? What are the main hurdles?
There are several practical things like logistics, getting biopsies, running the assays reliably. Cost is a factor. Standardizing the assays so results are comparable between different institutions is a big challenge.
And the need for solid evidence.
That's probably the biggest one. You need large, well-designed prospective clinical trials to definitively prove that using a specific assay to, say, escalate dose for resistant tumors or de-escalate for sensitive ones actually improves patient outcomes, like improving survival or reducing toxicity compared to standard approaches. Generating that high-level evidence takes time and resources.
So the potential for truly personalized radiotherapy is huge, but translating these cool radiobiological insights into everyday, evidence-based clinical practice on a mass scale is still a work in progress.
Precisely. It's a major focus of current research, but there are significant hurdles still to overcome.
Okay, so let's try and summarize the key points from our discussion today.
Sounds good. We started with the absolutely critical concept of the therapeutic ratio, that essential balance between TCP tumor control probability and in-TCP normal tissue complication probability. Widening that window is the name of the game.
Right, and we saw how the TCP curve is influenced by key biological factors. Think SOR size, cell number, oxygenation, hypoxia makes it harder, intrinsic radiosensitivity measured by assays like SF2, and repopulation kinetics.
We then explored some of the predictive assays designed to measure these factors. For sensitivity, the clonogenic assay is gold standard, with SF2 and colorimetric assays as surrogates. For hypoxia, F18 MISO-PET is key for non-invasive imaging, alongside probes and markers.
Acknowledging that while these assays are biologically informative and promising, their routine use for individual dose tailoring is still largely investigational, pending more validation.
Exactly. And finally, we discussed how treatment strategies like fractionation inherently improve the therapeutic ratio, and how modifiers like radiosensitizers, not discussed in detail today, aim to shift TCP left, while radioprotectors like emifusine aim to shift NTCP right, both working to widen that crucial therapeutic window.
It really all comes back to optimizing that ratio.
It does. Understanding these core concepts is just fundamental for any radiation oncologist.
Well, thanks for joining us for this session today.
My pleasure. We hope this review helps solidify these core radiobiology concepts, whether you're studying for boards or just refreshing your understanding for clinical practice.
Absolutely. As we look towards the future, perhaps the ultimate challenge isn't just developing more sophisticated ways to measure SORR, but proving we can consistently and effectively use that information to make each patient's therapeutic ratio just that little bit wider.
Well said. Complete practice oral boards at radonsmartslearn.com and subscribe to Radon Smart Review for our next session. Thanks everyone for tuning in.